We are good to go.
Yeah.
A very good afternoon to everyone. This is Dr. Sandhya from Pune Obijaya Society, welcoming you all on behalf of Pune Obijaya Society. And today we have yet another webinar in the series of Cutting Edge series. And today's webinar is in association with Yavatmal Obijaya Society. So I request Dr. Vaishali ma'am to give her opening remarks.
Thank you, Sandhya. We are indeed truly honored, and it's a great privilege for us to be associated with a very vibrant society, the Yavatmal OBGYN Society, and two very highly esteemed guest of honors, Dr. Girish Mane and Dr. Kalyan Baramde, who are with us today to give us their blessings and their best wishes. This webinar has been the brainchild of Dr. Meenu Agarwal, and we have this every Tuesday 4 to 5 p.m. And as you know, Dr. Meenu Agarwal is contesting for the post of Vice President Foxy West Zone. I request all of you who have logged in, all the delegates who have logged in, to please vote for Dr. Meenu Agarwal, as she is truly a deserving candidate, and she is excellent academician in all fields, whether it's imaging, ultrasound, laparoscopy, ART. So she's truly a deserving candidate. And as we proceed, I would request Dr. Aarti Nimkar and Dr. Meenu Agarwal to give a welcome address for everyone.
So good evening, everyone. Today is our another episode of Cutting Edge webinars. So Kalyan and Girish, actually we started these webinars a few months ago, and we are taking one topic which is little advanced in ART or endoscopy, and we are taking one topic which is related to obstetrics, again more of the joyful motherhood. We have been having very good attendance and very good reviews. One of the Tuesdays we did not do our cutting edge, and I got so many messages that why we are not having a cutting edge today. We did not get the link. So it's become quite popular with everyone. And I started when I was the POGS president, and Vaishali was the general secretary, and Charu Bapai was the clinical secretary. And I'm very happy that the next team of POGS, Dr. Aarti Nimkar Madam, Dr. Meenakshi Deshpande, and Dr. Amol Lumkar, they decided to continue with this webinar series. So thank you very much, Aarti Madam, for continuing this, and over to you. Thank you. And thank you, Yavatmal Society, for agreeing to associate with us today. So we are very happy to have the Yavatmal Society. And today we will also be having our next speaker, Dr. Meenakshi Deshpande, who's the General Secretary of POGS. Thank you very much.
Aarti Madam, we request you to say a few words.
Hello everyone, I am Dr. Aarti Nimkar, welcoming you from the POGS of the Pune as a president. This webinar is very popular, becoming very popular, and we continuing this, and I think the popularity will increase day by day, because many of the societies are connected with this, and we can exchange our expertise, presentations and thoughts to all over India. So welcome Dr. Girish Mane as a chairperson, and Kalyan. We think that these are our own persons in the Maharashtra.
Absolutely.
So, like a family. And now the chairpersons for the Meenu's presentation, the Charuta Ranade ma'am, president of the YOGS, and Sushma Tarak, secretary of the YOGS. And second presentation will be by Meenakshi Deshpande, intrapartum care for the joyful motherhood. And for her chairpersons are Uma Vankade from Pune and Amol Dunkar, our clinical chairperson. So Sandhya Mishram is our MOC. Sandhya, you can take this webinar forward.
Thank you, ma'am, for your kind words. I request that we'll have a short prayer before the guest of honors give their blessings. So can we have the prayer song?
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु
Thank you.
Dr. Girish. We would like to introduce Dr. Girish formally.
Yeah.
Sir,
Sorry, ma'am.
Can
Yeah.
you put the CV, Girish sir's CV? And it's a great.
Actually, I think it's okay. It's okay.
No,
We are running short of time. We can
Please
continue.
give us a privilege, very short introduction, because I know there's a lot to say about you. It'll be unending, but just a few words. And as we know, Dr. Girish Mane is a dynamic young leader of Foxy, and his presence today has truly enriched our webinar. He has been past chairperson of Adolescent Health Committee, during which he was awarded as the best committee also, and he has been past president of Yavatmar OBGY Society, right now Vice President Isopar Vidarbha chapter, and he has received many awards like Foxy Champion Award and awarded by Government of Maharashtra for his work during COVID pandemic, recipient of Dr. Durusha Youth Trophy, recipient of Dr. Sadhna Desai Award, recipient of Foxy Dira Award, and he has contributed 7 chapters to Foxy Focus, truly academician. And the amount of work he has done for adolescent has truly been revolutionary. And not only when he was chairperson of Adolescent Committee Foxy, but he has been doing this with Dr. Vrushali since a very long time. And I remember all the big meetings and social programs you would hold for all the adolescent children, school children. They were really a huge amount of work that you have done. And because of that, you are a truly respected Foxy leader. He has also been editor of Amox Focus Adolescent Healthcare. He's been doing great amount of work at Amox level also. He has presented many national, international papers, and he has been also the author
Thank
of.
you, Vaishali.
So
Thank
truly
you.
we are honored, Dr. Girish, and we request for your blessings.
Thank you. Thank
and
you.
Your best.
First thing, thank you very much, Vaishali, and thanks a lot, Dr. Minu, for inviting me as guest of honor. First thing, it's not a blessing from my side because I'm not that much older, as well as I'm a senior to all of you. So it's just a request on behalf of Minu and Dr. Sneha, who is member of Yavatmal Society, to everyone to vote for them because they deserve, not only because they are our friend, because they deserve the things, and that is the reason why they should be given votes from everyone. Okay, so respected Dr. Aarti Madam, Dr. Meenakshi, Dr. Amol, and everyone who is present in this webinar. A very good evening to all of you, and really hats off to you, Dr. Minu. You are working since so many years, and congratulations for your this webinar series that is cutting edge. And today's topic, that is decoding myomectomy, is very important because many times patients are coming to our OPD, and many times at least we people are in dilemma what to do with this myomectomy, because the size does matter, the placement of that myoma that matters, the age of patient matters. So there are many questions in front of the people like us who are not really doing a lot of work in this sector, I mean specifically for infertility. So we all are eager to listen what exactly should be our role or what should be our thinking regarding the myomas or fibroids, especially in the patients who are infertile. And also we are eager to listen from Meenakshi Madam, the intrapartum care for joyful motherhood, because many times we are very, what we can say, very formal in our OPD. We are not thinking about the mentality or what a doctor can give or what a doctor can do for making that motherhood very joyful. We are just treating the disease, and we are treating those mothers just as isn't it what Dr. Munna Bhai mein usne bola tha ki the person in front of you is only your subject, but Munna Bhai taught us that we should not treat them as a subject. They are human, and the emotional connect with your patient is very important. And Meenakshi Madam, really we are waiting for your speech and what we can do in intrapartum care for the joyful motherhood of that lady. And I think we are running short, so I will stop here. And my request to everyone to vote for Dr. Sneha as well as Dr. Minu. These are the deserving candidates. And Minu madam, we are always with you. Don't worry. And Yavatmal Society specifically is with you. And over to you, Vaishali. Thanks again for this invitation. Thank you very much.
I think you caught the nerve of both the talks very clearly, Girish. Thank you.
Thank you.
Thank you for your best wishes, and thank you for the blessings, and thank you for this wonderful the guest of honor speech that you gave. Thank you.
Thank you. Thanks a lot.
Thank you, sir, for your kind words. I request Vaishali ma'am to introduce Kalyan sir formally.
It's again a great privilege for me to introduce Dr. Kalyan. And like Dr. Girish said, today we actually have two very young guests of honors, and they are very young, but at the same time, they're highly accomplished. And Dr. Kalyan Baramde is truly a stalwart, not only in laparoscopy, in ART, but in everything that he does. And he's also a true leader of FOXY. His tenure as chairperson Public Awareness Committee FOXY, he took it to a great level which had never been done before, and the amount of work he did all over the country and the big rallies he held were truly phenomenal. So Dr. Kalyan is director of Barmade Hospital IVF Center Latur. He is vice president IIG, and I think one of the youngest president of IIG when he takes over as president. And we look forward to your presidentship, Dr. Kalyan. He is IIG 2020 to 21. He is a very well-known gynec endoscopic surgeon and ART consultant, and he has performed more than 8,000 advanced endoscopic surgeries and has trained many doctors in endoscopy. And he's truly a national, international, very well-known, very acclaimed faculty. And your presence has truly enriched our webinar. And we are truly honored to have you here. And we request you to give us your best wishes.
Thank you, ma'am. I'm really thankful to Dr. Vaishali ma'am, my senior from KM, who has such a great words for me. I'm not that senior, ma'am. So I thank POGS, Dr. Aarti madam, Dr. Vaishali Chavan madam, and Dr. Charulata Bape ma'am, and my friend Dr. Amol Umkar as clinical secretary. We have our MOC as Dr. Sandhya Meshram, who is doing a great job. As everybody knows, this is a POGS webinar, cutting edge for Yavatmal OBGYN Society, or with OBGYN Society of Yavatmal. So Pune and Yavatmal has very distinctive role to play in FOXY next year, because these both girls are going to win the elections this year of FOXY vice president, and this is a unique milap आहे ज्याच्यात यवतमाळ आणि पुणे एकत्र येत आहेत. That is really great. Pune is famous as Vidyeचं माहेरघर, and Yavatmal is famous for Tipeshwar Wildlife Sanctuary, Chintamani Ganesh Mandir, and Kinvat Wildlife Sanctuary. So this is a unique combination of Pune and Yavatmal society, which is very well appreciated all over India, because Dr. Minu and Dr. Sneha ma'am are standing for the elections of vice president. We wish them all the best for the elections. Coming to the cutting edge webinar, again, the speakers, Dr. Minu Agrawal and Dr. Minakshi madam, are going to throw light on the subjects of decoding myomectomy, because myomectomy is a very close and dear topic to Punekars. They have unique people to do documentation that is called as fibroid mapping. The images of Pune are all over the world. Dr. Sunita madam in her many presentations have shown the images, which are really good. And anytime you are doing a myomectomy, the fibroid mapping plays a bigger role. So I'm going to listen to Dr. Minu Agrawal madam, how she's going to talk about this role of mapping and role of lap myomectomy. I am waiting eagerly to listen to Dr. Minakshi Deshpande madam for intrapartum care of joyful motherhood. And I wish all the best for this webinar, and I wish Dr. Minu Agrawal ma'am and Dr. Sneha Bhuyar madam for the elections. I am thankful to Dr. Aarti ma'am, and Dr. Amol Lunkor, as well as my senior Dr. Vaishali Chavan madam, for this opportunity. Thank you so much.
Thank you, sir, for your kind words. And with this, we move on to the ma'am. Would you like to say a few words?
Yeah. Kalyanis, thank you very much for these nice words and about the Pune city and Yavatmal and Latur. And we are, I think, all part of Maharashtra, and we are all very
Together.
close to each other. In some kind of a way, we are connected very well. And Kalyan is not only a great, very big foxian and everything, but he's also very warm-hearted. कभी भी मिलो तो ना ऐसा लगता है प्यार आता है उसके ऊपर. So very warm-hearted, very hospitable. You go to his city, Latur, he will do everything for you. He'll make sure that you are most comfortable. So that the many qualities about you, Kalyan, and I'm sure you have much big way to go ahead. You are very young still, so wish
Yes,
you
ma'am.
all the best also.
Thank you, ma'am. After Vaishali madam, my turn. Okay, ma'am.
Yeah.
Dr. Meenu and Vaishali, I have one complaint. We
Yes,
had been to Yavatmala. We are eagerly, after you should to Yavatmala at least once.
surely.
Same complaint is with Kalyan also. We are waiting for Kalyan also. आरती मॅडम पण जवळ येऊन गेलेत पण नाही झालं इकडे येणं पण वी आर eagerly waiting कल्याण राव आणि मॅडम and मीनू चलो we are eagerly waiting for both talks.
Yeah, so with this, we move on to the first session, and to chair the first session, we have Dr. Charuta Ranade. She's the president of Yavatmal OBGYN Society. She hasn't joined, but probably she'll join in few minutes. She's a senior consultant obstetrician gynecologist from Yavatmal, practicing since 19-20 years. She is the director of Ashwini Nursing Home and has a special interest in high-risk obstetrics, menopause, and maternal critical care. And the next chairperson is Dr. Sushma Tarak. She is the secretary of Yavatmal OBGYN Society. She is a member of FOXY, IMA, ISOPAP, Adolescent Health Academy. She is the associate professor of SVN GMC Yavatmal and also the nodal officer for maternal mortality Yavatmal district. She's attended many national and international conferences and has many publications to her credit. Welcome, ma'am. And I request Dr. Sushma Tarak to please introduce Dr. Meenu Agarwal formally for her talk. Madam, Sushma madam.
Hello. May I audible?
Yes, ma'am. Yes, ma'am. Audible.
Okay. Good evening, everybody. And thank you for the nice introduction.
Dr. Sushma, I think आप दो उस डिवाइस से लॉगिन हो तो it is echoing.
दो जगह से नॉइज हो गए.
Audible?
Yeah, no better.
Okay. Thank you, ma'am, for nice introduction.
तुझे दोन डिवाइस चालू आहेत का?
नाही, एकच आहे.
ओके ऍक्च्युली इट्स इक्वलिंग.
अच्छा, नाही एकच आहे सर. एका लिव्ह झालं मीटिंग तिथून.
Okay,
It's my privilege to introduce Dr. Meenu Agarwal, ma'am. She is a immediate president of Pune Obstetrics and Gynecological Society. She is elected Secretary General for the International Society of Gynecological Endoscopy. She's a chairperson for the FOXY Imaging Science Committee. And she's a course director for the endoscopy and ART training courses in EAV. She's the first author of 4 books and authored many chapters. She received many awards, including India's Greatest Leader by Asia 1, Icon of the Health by Times Groups, Inspiring Gynecologist of West India by Health World, and FOXY Champion of FOXY Award. Ma'am, over to you.
Thank you. Thank you, Dr. Sushma Tarak, Secretary, Yavatmal OBGYN Society, and thank you, Dr. Charuta Ranade, who will be joining a little later. So I shall be now talking a bit about myomectomy and decoding myomectomy. So, one moment. I hope you can see my screen. Okay, all right. Just 1 minute. Can you see my screen? Can you
Yeah,
see my
we
screen?
Yes,
yes,
ma'am.
Emil. Yeah, Emil.
Yeah, okay. All right. So, good evening, everyone. And I will be giving a very quick talk on decoding myomectomy. We understand that fertility management, there are a lot of different evidence which I shall be discussing. Laparoscopic myomectomy and when to go for the hysteroscopic myomectomy. A lot of factors which because of their fibroid it can cause fertility issues with the patient, maybe by obstructing the fallopian tube sometimes if they're near the cornua, or by impairing the gamete transport. Another thing we should keep in mind is these women with fibroids are also prone to early pregnancy losses, so that point also should be kept in mind. Professor Kurt Sem reported the first laparoscopic myomectomy in 1979 along with Professor Lilo Mettler. However, this was not taken very kindly by the peers. They, in fact, they thought that something is wrong with his brain, that he's talking that you could put in a small tiny telescope and you could do a myomectomy, which was considered as a very, very big surgery even today and even at that point of time. He was, in fact, also asked to get an MRI of the brain done, that he was talking such nonsense. Today we are very it's this procedure has been standardized. When we started doing myomectomies, we used to give a vertical incision. There were two reasons. One, we thought that the blood supply is lesser in the midline of the uterus, and also because we were using contralateral ports, it was easy to suture. However, with time we understood that low vascularity, less bleeding will also give us not a very good scar strength. So it is better to go for a transverse incision and then close it nicely with ipsilateral ports. So today we are, all of us are very comfortable with ipsilateral ports. We can see here, this is our primary port here. Then this is the anterior superior iliac spine. First secondary port about 2 centimeters medial, and you can also go superior if your primary port is higher, and the second port will be in between these two ports. So if you are putting an additional port here, you can even go here. Some people use this particular line for suturing, which is also a good method, but this is what we are using. We find it very, very comfortable to use these ports. But this port should always be equidistant between your first secondary port and the primary port. Very important is to get a pre-operative good imaging. So we should know which fibroids are we going to remove. Now this patient I will remove, maybe I have counseled the patient to remove this, I'm sorry, to remove this fibroid, and this fibroid need not be removed. So accordingly, I could tell the patient that I am going to leave these fibroids behind because they are not causing any trouble to you. So 6 months later, if she does an ultrasound somewhere else and finds out that there are still fibroids left, she will not be disappointed because you have already counseled her. And with these images in the OT, it becomes much easier for us to actually decide and then go ahead for the myomectomy. So we can, in selected group of patients, we can also do an MRI, which will exactly tell us if this fibroid is nicely compressing on the endometrial cavity here, and that can be seen very well on MRI. सो हाउ टू रिड्यूस द ब्लड लॉस. सबसे पहला टेंशन क्या रहता है कि ब्लड लॉस ज़्यादा होगा मायोमेक्टमी में. व्हाट वी कैन डू, अगर हम हिस्ट्रोस्कोपिक मायोमेक्टमी कर रहे हैं तो वी कैन यूज GnRH एगोनिस्ट. वेरी वेरी गुड ऑप्शन. Give monthly GnRH agonist 1 or 2 cycles. Suppose 4 centimeters submucosal fibroid, and don't hurry up to do it. Wait for 2 months, give GnRH agonist, and you will find the fibroid size has gone down to 2 centimeters. Also, when we are doing a myomectomy, the blood loss is much less. Vasopressin infiltration can be done both for laparoscopic and hysteroscopic myomectomy, and for laparoscopic myomectomy, we can also go for clipping of uterine and IP ligament. So this is how we use 10 units in 400 cc. For laparoscopic, we inject it just between the capsule of the fibroid and the myometrium. And for hysteroscopic, we inject it in the cervix between, not at 3 and 6, so 2 and 7, or 4 and 5, so 4 and 9. So you can use all those positions. Just don't inject at 3 and 6, because that is where you will have the uterines over there. So yeah, very, very important again to find the right plane for the myoma. So that is most important thing. Even if you give a little incision on the fibroid, does not matter at all. See here, I'm sorry. So yeah. So even if you give a little incision on the fibroid, there is no problem at all, but don't go into the wrong plane. So here you can see a small incision the cut has been given on the fibroid. Does not matter. The moment you see you're going into the fibroid, you know you are into the right plane. You just come, leave that portion, and then find the right plane and go ahead. In some cases, we might also want to clip the uterine at its origin. It's absolutely fine, especially when the fibroids are located at very odd positions, cervical fibroid, large cervical fibroid. So those are the patients where we can go retroperitoneal. We can either go lateral to the IP ligament, or we can go medial to the IP ligament. If the fibroid is occupying a lot of space posteriorly, then it is easier to go lateral to the IP ligament. And if it is an anterior wall fibroid taking a lot of space anteriorly, then it is easier to go medial to the IP ligament. And once we find the uterine artery, if it is a infertility patients, then we can either put a clip, or we can also use that stitch with Sanket Pisak has very nicely internationally published, that shoelace kind of a knot that can also be done. So these all possibilities are there with us, and sometimes then we can use these possibilities. One more point I would like to say: when the fibroid is situated, we can use a tenaculum. Like, you see single tooth. This grasper is very, very nice, very versatile. You see here. So don't use the myoma screw. So if you use this particular tenaculum with one tooth here and one tooth here, you can rotate it anyhow, and it really gives you a good traction for the removal. Suturing is same, like we normally use V-lock at our center, and these are unidirectional sutures. And I always feel whoever thought of this putting barbs on the suture, I mean, must be a real genius, because he not only made the lives of the women who are undergoing the surgery, but also of the surgeons, because the surgery is much quicker, the blood loss is much less, and it is less time of anesthesia. So in every which way, it is a very comfortable thing for the surgeons and for the patient. So the only suture that is taken is when you pass the needle through the loop. The loop is at one end, and you pass the needle through the loop, and that is all which is done, the first stitch. And after that, we just take either continuous stitches, or we can take baseball stitch. Both are fine, whatever, depending on the depth of the incision that you have taken. Then of course they behave like continuous interrupted sutures, and there are no knots. Jab khatam ho gaya, we just cut it at the base, and that is all that we are done with it. So less anesthesia time, less operative time, less blood loss, and the suturing time is reduced by 58%, which is a huge thing. So now Dr. Girish Mane said इनफर्टिलिटी पेशेंट्स में थोड़ा कंफ्यूजन है, कौन से फाइब्रॉइड को रिमूव करना है, कौन से फाइब्रॉइड को वी कैन लीव बिहाइंड. Now she is a 26-year-old lady, primary infertility for 2 years. Everything is normal with her semen parameters, ovarian reserve. However, she has 1 centimeter submucosal fibroid. Now, whether to operate on her or whether to go straight ahead with whatever we are planning for her. So, what does the evidence tell us? So, evidence tell us that whenever we have submucosal fibroid, cavity distorting submucosal fibroid, then a myomectomy may be considered to improve the pregnancy rates. So very clear evidence tells us that this particular patient, we should do a myomectomy for her. Since she is young, since everything else seems to be fine, maybe we could either she can try with timed intercourse or we can go for IUI for her. Now, whenever we are operating on submucous fibroid, few things we should keep in mind. One is that we should keep the loop at all times under vision. Very, very important. Suppose there is a bleeder, slightly increase the pressures, bleeding will stop. Again, reduce the pressure before you go ahead. Look at the bleeder, coagulate the bleeder. Otherwise, the fluid will be going inside the vascular channels, and in a matter of a very short time, there is a possibility that patient can go on to fluid overload. The third thing which we should keep always in mind is suppose there are a lot of other pieces are floating inside. Okay, so we want to just let all the pieces come out. तो हम लोग पूरा contraption we take out, and while we take out the contraption, उसके हम pieces निकाल रहे हैं, patient is all exposed and the air embolism. So that is one thing. If the vascular channels are open and the cervix is also open because you have dilated and put your resectoscope, the air has a big it's a big risk here, and once the air finds its way, in no time your anesthetist might tell you that, oh my god, the patient is sinking. And we have had 2 or 3 patients, I think Dr. Kalyan will know about those patients, those cases where young patient were lost to hysteroscopic myomectomy. So whenever the moment you take out your contraption, take one Ellis forceps and just apply it on the cervix, or tell the nurse to take a mop and keep the vagina, the perineum covered till you go ahead for the very small protection, but that is what prevention of complication. Bigatti shaver, again, Dr. Bigatti is a very good friend of mine, and this is an excellent innovation that he has done. It works as both as a suction as well as a morcellator. So you have a foot switch, you press the foot switch half, the suction starts, you press it more, then the morcellation starts. So a 1 centimeter fibroid, I think, will not take more than 40 to 50 seconds to complete. And again, it is just a mechanical energy, excellent for patients with infertility. Sometimes these patients also have FIGO 1 or FIGO 2 fibroids. They are deep-seated fibroids. So there are some things which have now come up internationally when we listen to these speakers. They say that you can just cut the endometrium, make some cut on the endometrium, और यहाँ पर छोड़ दो उसको, कुछ मत करो, इतना करके छोड़ दो, and then go for the second sitting after 1 month. And what you will find that this fibroid has popped into the cavity. So from FIGO 2, it has become FIGO 1 or FIGO 0. Second thing is, we can here what I have done is I have used a myoma screw because I wanted to finish in the same sitting. So I put in a myoma screw, and this myoma screw can make FIGO 2 to FIGO 1 or FIGO 0. ये पूरा fibroid निकालेगा नहीं, it will break. It's a very delicate instrument, और in fact आपका वो piece उसमें रह जाएगा, तो you will be struggling to take out that piece. So very gently at a right angle you pull it, and you make this from FIGO 2 to FIGO 1 or FIGO 0, and then go for the resectoscope and do a myomectomy. This is another patient. She is 33 years old. Her husband has oligoasthenoteratospermia. Tubes are patent. She has a 4 centimeters asymptomatic intramural fibroid. Should we take it out? Should we go ahead because she needs ICSI? Should we straight go for ICSI for her? So what does the evidence tell us? Evidence tells us that she can go ahead for the procedure. Then we have another lady here, 37 years old. Everything else seems to be fine. She has bilateral tubal block, and she has a 4 centimeters intramural fibroid which is slightly impinging the cavity. So what do the evidence tell us? Evidence tell us that whenever we have cavity distorting myomas, okay, then myomectomy may be considered to improve the pregnancy rate. So these patients should go for a myomectomy. So we have three kinds of patient: subserosal, don't touch; intramural, don't touch; submucous should be removed; intramural, which are impinging onto the cavity, should be removed. So this is what at the moment the evidence is telling us. So whenever we are using this intramural which are impinging on the uterine cavity, we have to keep in, your assistant should not be very strong or very enthusiastic, because if you pull the fibroid very hard, sometimes you may open the cavity, so you may breach the cavity. So always put methylene blue. Every patient, in fact, I do a lot of workshop with Professor Medler, and she always insists every patient of myomectomy put the methylene blue. So we only put it when we are suspecting a breach, but we can put it for every patient as well. And just check, no problem, even if we have breached the cavity, only two things we should keep in mind. One is that we should go very close to the fibroid. When we are cutting, go very close to the fibroid here. Tell your assistant to push the endometrium. And I was going through one study where they said that if you cut the Surgicel, छोटा सा piece cut करके, and push it over the endometrium which is jutting out, वहाँ पर Surgicel रख के and then you suture. So I have done it, and that will reduce the adhesions. So last two patients, incidentally, where the endometrium was jutting, one it was open and one it was not open. So I used the Surgicel and then I closed the myometrium. So again, one adenomyosis is, again, I think I can skip this, but in adenomyosis also we can debulk. Now surrogacy is becoming so much difficult, so we are doing debulking of the adenomyotic uterus. Only two things we should keep in mind. One is, even if it is a large 16-week size का adenomyotic uterus है, don't go very deep. को लगता है यूट्रस बहुत बड़ा है, but very easily you can open the cavity. So that thing we should keep in mind. And second is that you suture in flap like method. So the tip of this first will get sutured to the base of the other side, just like we wear a double breasted coat. Like that we are suturing, and we are getting a good strength of the suture. Then morcellate or not to morcellate young patients when we are operating. In fact, recently Bhopal, I was there. There one doctor said, a 31-year-old, she did a myomectomy and it turned out to be a uterine sarcoma. So we, as per AGL guidelines, we must tell the patient that there is 1 in 10,000 or whatever chances of her having a sarcoma, and she gives consent of morcellator in spite of knowing all the things. So that is important. Morcellating in the bag actually will not reduce any sarcoma spread, but the small pieces which scatter around, that will reduce, and that is will be much better time saving after the morcellation is done. This was one case where we actually had a case of myomectomy scar ectopic, which was a very, very unusual case. And we finally managed to do it under as a laparoscopic procedure. And you can see here, we treated it just like a cornwall pregnancy. The whole of the myomectomy scar was incised. Actually, she conceived after embryo transfer, came with a missed abortion at 9 weeks, gave her medical management. She did not bleed. Then we did a DNA for her, and on DNA also she did not. We did not find any products of conception. So we put in a hysteroscope. The cavity was empty, and that is how we actually diagnosed her as the myomectomy scar ectopic. And then this whole scar was incised, excised, and the products were removed, and it was then closed in 2 layers, and then the Surgicel was placed, and she did pretty well post surgery. We actually also published this case. This was the first case 2017 we published. उससे पहले एक केस जिसमें उन्होंने methotrexate दिया, और उससे पहले एक और केस था where it was more of a subserous ectopic. So this was the first case reported laparoscopic management, and then PG Pulsar also reported one case in the same year. Then how many fibroids to remove? Irrelevant. Don't think 20 nikale, 25 nikale, 30 nikale. Do a good mapping. Find out the fibroids which are actually causing the trouble. Sometimes to remove that fibroid, you have to remove a fibroid sitting outside also. So in the same incision, sometimes you have to do a good preoperative planning, good surgical technique. Find out the ways to reduce the intraoperative blood loss. How are we going to retrieve these specimens? Now, since we are doing so many myomectomies, we have so many videos. So, no, this is a new instrument. This is a laparoscopic ultrasound probe. So, from our 5 mm port, we can put it inside, and this has got a ultrasound tip here, and it will tell us if you are missing out on any fibroid. It will also tell us, the hyperactive areas in liver, spleen, also to take the biopsies for the tumor locations. So this is something very futuristic, not yet available, and we are looking forward to have these kind of innovations to make our life easy. For the juniors, do not settle on laparoscopic prematurely. ऑलवेज एस्टिमेट कितना टाइम लगेगा सर्जरी में. अगर लगता है 26 वीक साइज का यूट्रस है, मल्टीपल फाइब्रॉइड्स हैं, यू आर नॉट वेरी वेल वर्स्ड विद लेप्रोस्कोपिक, आई एम 100% will agree with you if you say, madam, I will do open myomectomy. There is no problem at all. It's not an ego thing. So we can always go for an open myomectomy when we feel that it is required. Uterine artery embolization also many people are doing. That is also a good option. Patients who have menorrhagias and they don't want to let go of the uterus, so those are. But infertility patient, I think uterine artery embolization is not a good idea. तो नया करना है तो preferably take posterior wall. Don't take very big fibroid, not 6, 7, 8 centimeter. उतना बड़ा मत लो, 4, 5 centimeter का लो. Posterior wall लो. Previously कोई surgery उसका virgin abdomen है, that is much better. And don't take very obese patient to begin with. So these are the some few points that I should tell you. And if we have anything else by the respected chairpersons, please you can put your point through. Thank you very much.
Thank you, ma'am, for a wonderful talk. Sushma, madam, are you there to give the concluding remarks? Sushma,
Yeah.
madam? Yeah. Thank you, ma'am. Yeah.
Thank you, ma'am, for such a wonderful talk. It's a need of hour for the laparoscopic myomectomy. Everybody knows about the decoding of myomectomy, ma'am. Thank you, ma'am.
Thank you, Dr. Sushma. Thank you very much.
Girish sir, could you please give your comments as well? We would like to hear from you as well. Kalyan sir, would you please give your comments on ma'am's talk?
Kalyan, you are muted. Kalyan, you are muted. Kalyan, you are muted.
Superb talk, Minu, by the time Dr. Kalyan joins. So excellent talk as always. Every video of yours is so perfect and such. It has been a visual treat watching all your videos, and every Tuesday I listen to your talk and learn more and more. So you truly are a great teacher and who's been teaching everyone all your skills. So thank you very much.
Thank you, Vaishali. Coming from you actually boosts my morale because you yourself was such an excellent laparoscopic surgeon. So coming from you, it's really a great compliment. Thank you.
Thank you. So with this, we move on to the next session, and the next
Dr.
session is
Girish
on.
is here, Sandhya.
Yeah.
Dr.
Yes,
Girish.
ma'am. Yes. Yes.
No. It's okay. You continue. वैशालीला पाठ झाला असेल ना आता हा टॉपिक.
Yes.
We change topic every time. We don't give the same topic, Girish.
No. But madam, after doing so many programs, the topic must be repeated, no, for once or twice.
Yeah, but all Minu's videos are superb. You know, there's
Yeah, I know.
different videos. There's a huge, vast amount of work she's doing. Very interesting talks always.
Yeah. And specifically when you are giving talk on a subject which you are doing in your day-to-day practice now, it's very interesting for the person who is giving the talk, and you can share many ideas also because you are doing it practically, correct?
Yeah, you're right. कभी कभी मुझे मतलब ऐसा कुछ और टॉपिक देते हैं जिसपे we are not doing it every day.
Exactly.
But you don't speak from the heart then. You're speaking.
Right. Exactly.
The slides then.
It's a formal talk more.
Yeah.
Thank you.
Thank you, Girish.
So with this, we move on to the next session, which is on intrapartum care. And for that, I would like to invite our chairpersons, our esteemed chairpersons, Dr. Uma Wankhede. She is a professor and head of the department, Government Medical College, Baramati. She is the examiner for MBBS, CPS, DGO, MS, and DNB exams. Certified trainer of GDM for physicians. She has a Fogarty Fellowship from Johns Hopkins University, USA, and published more than 50 scientific papers. Speaker at many local, state, national, and international conferences. Welcome, ma'am. Our next chairperson is Dr. Amol Lunkad. He's not joined yet, but probably he'll join in a few minutes. He's at present the clinical secretary of POGS. He's the chief IVF specialist of Indira IVF Pune. He's a founder member of Gynae Endocrine Society, and he's been awarded various awards: Indumati Zaveri Prize, Pune Times Men of the Year, Pune's Most Powerful Achiever, Hall of Fame IVF Specialist of Western India, to name a few. Welcome, sir. Most importantly, he's the go-to person for us in POGS in case of any problems. So welcome, sir. And I request Dr. Uma Wankhede to please introduce Dr. Meenakshi Deshpande formally for her talk.
You can hear? Hello?
Yes, we can hear you. We can hear you.
Thank you so much. Before I introduce Dr. Meenakshi, I would like to wish Meenu all the best. And I'm 101% sure that she'll safely sail through. And we all are there. Our prayers are with her and our best wishes are with her. And she's so accomplished and so experienced and so talented that I don't think there's a match for her with anyone. So all the best, Dr. Meenu. And now it's my pleasure to introduce Dr. Meenakshi, who is the secretary of POGS at present. She was past president IMA for 22-23, and she's practicing since 30 years at Vatsalya Hospital. And she has got many awards like the IMA Kanak Goyal Award, the Apulki Award. But what I want to say, Meenakshi, it's not written is that you're past LLB. For me, that is a very creditable thing you have done. So I think you should update your CV. And you always pioneered safe motherhood, because I am seeing so many training camps you organized in the last 2-3 months. So over to you about intrapartum care.
Yeah, thank you, Dr. Uma. And before I start, even I would like to wish Dr. Meenu all the best for becoming the Foxy Vice President. She's one of our candidates who is damn sure, and we are damn sure that she will be there. So Meenu, you don't worry, I think.
Thank you,
be there from all of us. Yeah. Because I think the whole Maharashtra, and not even Maharashtra, many other states are also behind you. So like, it will not be a matter of much concern. I think can you please announce your dates of voting? When is your
1st to the 10th of August. 1st August, it will open the voting link.
Yeah. So that is good enough. So we would request all people, all the doctors, all the attendee delegates, the professors, lecturers who are also joined today to vote for Dr. Meenu. and a prime candidate from POGS. So yes, thank you, Dr. Uma and Dr. Amol, great chairpersons for my talk today. And I'd like to share the screen. Yeah, can you see the screen now?
Yes.
Yes, we can see the
Okay, then
screen.
I'll make it
full
yeah,
slide
full
show.
screen. Yeah. Yeah. So thank you. And we will start with this talk. It's a very beautiful talk. Hello. Yeah. This is a different type of talk which we are having today, which we have a program labor. I think this topic has not come up in this slide, but basically this is an intrapartum care which we give for program labor. That is how you know that whenever you try to induce patient, can you really predict where the patient will deliver and whether there will be any complications during that program labor, and whether you can say that this patient will have a normal delivery or a C-section or a normal, progress of labor. So this concept of program labor rests on 3 pillars. First is providing optimum pain relief, that is use of analgesic and antispasmodics well in time, in proper doses, and giving at the time when patient requires it most. Then second is the ensuring adequate uterine contractions, like active management of labor. You have to ensure adequate contractions so that there is no delay in whatever time limits you have put for yourself. And close clinical monitoring of labor events, that is maintaining a partogram. So active management of labor, as we all know, it was a concept advanced by the Irish school. So in 1973, O'Driscoll and his colleagues reported on the advantages of active management of labor, resulting in shorter labor, improved obstetric outcome, and lowered C-section rates. So whatever we want, like these are our, aims and objectives of a program labor. So why do we take a program labor? Those indications also I'll go through shortly. But active management will also involve all the aspects which are there to prevent infection, to prevent maternal exhaustion, to prevent the dehydration in mother, to prevent disillusionment in the mother, prevent fetal distress, and of course, prevent ketosis, because that is the maximally thing which we are afraid of. So as you all know now, this is the partogram where we have a normogram, then we have an alert line, and then we have the action line. Normally, we don't allow the partogram to go into the alert more than the alert line. So we take actions near the alert line itself. So how do we go for patient selection? Now, patient selection means what are the indications of program labor? Maybe there may be some indication, but there's no identifiable medical or obstetric complications presently. It should be a primigravida with a singleton pregnancy with cephalic presentation and with spontaneous onset of labor. Gestational maturity of 37 to 41 weeks. Admission NST should be reactive, yes, because you are going to augment the labor properly. And active phase of labor should be starting with cervical dilatation of more than 3 centimeters, that is 4 centimeters, and more than 50% effaced. So if we have all these things criteria in place, then we go in for the program labor for selected patients like primi or multi more than 38 weeks of gestation. Patient should be a low-risk patient, as we told before, with no medical or obstetric complications at hand. There should be a presence of anesthetist and neonatologist on call. That is, they should be available immediately, say within a matter of 10 minutes, as soon as you decide to intervene. Of course, the matter of consent should be there. That the patient should be told that we are going to program your labor, we are going to augment your labor. But anytime there is a chance of fetal distress, anytime we get an indication of fetal distress, we have to stop this program labor and going for a emergency C-section. And during the active phases of labor also, we can go in and think about having a future program labor. Now, what are the patients who are not to be considered for such an intrapartum care? Is all the complications which we encounter during normal pregnancy and normal labor, like antepartum hemorrhage, preeclampsia, preeclampsia, diabetes complicating pregnancy, polyhydramnios, oligohydramnios, a suspected strong suspicion of cephalopelvic disproportion. Cephalopelvic disproportion, many times we cannot, predict before. We only get to know when there is a delay in progress of labor. But sometimes, in many cases, we get to know that this patient is going to have a cephalopelvic disproportion. So in such cases, it is better not to go in for augmentation, malpresentation, and premature rupture of membranes with infection. So the medication protocol for intrapartum care begins only after the patient enters the active phase of labor. So cervical dilatation, 3 centimeter or more, I told you, like it is not 3 centimeter. Patient has to go beyond. It should go beyond 3 centimeters. So nowadays we call it as 4 centimeters and beyond. Cervical effacement more than 50%. Uterine contractions come at a frequency of at least 3 per 10 minutes and lasts for 35 to 45 seconds. Head is to be engaged. There should be no clinical suspicion of CPD, and patient must have show or little bit of white discharge, which shows that the cervical effacement and dilatation has initiated. So what medications we can use in intrapartum care is a combination of drug where you can use a pain relief coupled with antispasmodic drugs which help cervical softening, yielding, and dilatation to moderate driving forces. As we all understand, there may be students also listening, it's a physics, The push given by the uterine contraction should be accompanied by the dilatation and the effacement of the cervix to give a proper flow of normal labor. So it's a cascade. It's a cascade which we initiate or we augment. And then it later on goes on an auto mode. And that is how we try to program or augment labor after the active phase has started. And what are the advantages of such a protocol? So we have this drug synergism, we have this pain relief, we have the dilatation which we are helping. So all these things, we try to enhance the physics of normal labor. That should be our aim. We don't try to intervene or we don't try to, make unnecessary changes in the routine partogram. But we have to augment the labor in such a way that the physics of normal labor is itself augmented. So we safeguard the mother and the fetus against adverse drug reaction. So the drugs also should be given in properly titrated manner, plus the descent of the fetus head as well as dilatation should be monitored. So we start with an intravenous drip. Then we start with oxytocin, IV oxytocin slowly, or we can start with misoprostol lowest dose. See that the pains are optimal, that the 3 or 4 sustained pains for 10 minutes. And if necessary, you can add a pain relief injection, that is a pentazocine or a Fortwin, 1 ampule of 30 milligram diluted with some normal saline or distilled water. And normally in a 10 ml diluent, if you dilute, then you can titrate the dose. You can give 1/5. That is, you can give 2 ml per dose. So what you give is 6 milligram of pentazocine and 2 milligram of diazepam, slowly in a bolus form through the tubing of the infusion line. And this 1/5, that is 2 ml, you can top up every time. So this is how you can titrate the pain relief so that patient gets optimum pain relief as well as concentrated, the uterine contractions are not hampered. And then this intravenous line with ringer lactate goes on in about 20 drops per minute. Then you at the same time monitor the fetal heart. The NST is going on, say, every half an hour or every hour as per your need. And then you go on increasing slowly, 2 more units of oxytocin to the drip and your tablets of misoprostol and then so that you ensure optimal pains resulting in a proper dilatation of the cervix plus effacement and plus overall progress of the labor every hour should be monitored on the basis of cervical dilatation, descent of fetal head, and document it periodically on your partogram. So this is an intrapartum care in which you give a programmed augmented labor. And when after all this, you get a properly advanced labor in few hours time with the fetal head pressing down on the pelvic floor, now is the time when patient starts getting more intense pain. It's a bearing down sensation. There's a severe pain. Patient is almost 7 to 8 centimeters or more than that dilated. And this time you can administer injection ketamine if you like. If you feel that ketamine is a better choice because it's a dissociative anesthetist, it is gaining popularity slowly day by day because it provides excellent pain relief, and as well patient is also satisfied. And patient can also push when we are giving a properly monitored dose of ketamine. So what is the level of analgesia which can be assessed? Now remember that anesthesia or pain relief can only be assessed by what patient perceives. There is no definitive scale for that. But 0 is no pain relief. That is, patient will say there is no pain relief, nothing. Nothing has happened whenever you give your injections. Second is day 1 is mild pain relief, 2 is moderate, and 3 is excellent. That is, patient is feeling a literally 90% pain relief, and she's just feeling the contractions coming and going. So now we look for the evidence. So this is our study group, and this is our control book. Now this study was done over 200 patients, in which you can see that normal delivery, vaginal delivery was achieved in 176 patients out of 200. That is about 88%. Whereas in control group, there was 162 patients out of 200. So, and of course, other like spontaneous unassisted delivery, low forceps assistance, ventouse assistance, and LSCS was 24 out of 200. So we are achieving you can say an ideal rate. This may not be in our own practice, but this is in the study group and the control group in which they have managed to get an ideal C-section rate of 12%, mean active phase of labor of about 3.5 hours, mean rate of cervical dilatation is 2.5 centimeters, mean duration of second stage of labor 26 minutes, mean duration of average blood loss is 3.5. That's third labor, mean duration of third stage of labor 3.5 minutes, and average blood loss is about 60 ml. And pain relief, as you can see, it is excellent in 24%, substantial or moderate in 62% pain relief, and none in nil. So we are getting some amount of pain relief with this schedule. And let us see now what we have for the conclusion part is that the rate of cervical dilatation, yes, was faster. Then duration of stages of labor was statistically different. It was really decreased duration of second stage of labor and third stage of labor. Pain relief score was much better. There was a good pain relief, you can say. Maybe not excellent, maybe not scoring 3, but score 2 was a better, good score. And complications, if we combine or compare in both the groups, there was a minimal difference, and side effects of the complication and of the drugs were minimally observed. So you can see that there is about 25 to 30% of difference between the control group and the study group, wherever we are using medications to program, augment, and augment the labor in such a way that we are getting a positive response. So these are the results which we are concluding after the statistical analysis. Majority of the patients in both the groups delivered vaginally, and pain relief was more. I mean, that is where I would like to focus, that 86 patients in the study group had pain relief as compared to 22% in the control group, which is statistically significant. And there were no side effects on the drugs which we had used, because minor nausea, vomiting was there, which subsided after, say, 12 hours. So these are the neurotropic agents and the musculotropic agents, and the 13 studies which we are having in front of us, in which 119, that is 19,095 patients, pregnant women were included in such studies, and we found that antispasmodics reduce the duration of first stage of labor by an average of about 75 minutes. That is more than half an hour, or more than 1 hour, that is. So we can say that more than 1 hour of our partogram we can have a properly randomized study to investigate the effect of valethamide bromide on the length of labor. Single dose of 16 milligram valethamide bromide was administered via the IV route in randomly selected 35 nulliparous and 37 multiparous women. The median time from complete cervical dilatation to delivery was 20 minutes in the groups which received valethamide bromide and 25 minutes in the groups that did not receive valethamide bromide. So there was a significant shortening of the second stage of labor in the nulliparous woman wherever we have utilized antispasmodic properly in time. So there is again a study of side effects which we have. So tachycardia, dry mouth, flushing, fever, headache, and nausea, vomiting can always be there comparatively to all the others, and not receiving valethamide bromide, we have got that these side effects were seen, but they were for a short period of duration, say about 10 to 12 hours. Now, this is one more study for the adverse drug, you can say effects, adverse drug effects, which were studied on these patients who were receiving valethamide bromide like epidocin or buscopan. So there was no statistical significance was found when ADR was compared between the age group of 18 to 25 years and 26 to 35 years. So adverse drug reactions reported were irrespective of the age of patients, and no life-threatening or severe forms of ADR were seen with hyoscine or valethamide bromide during cervical dilatation. I mean, even you and me, many of us use antispasmodics during labor. We find that there may be dryness of mouth. So most probably it is dryness of mouth, some vomiting, some dizziness, and usually patients don't complain beyond that. Drotaverine. So if we compare drotaverine with valethamide bromide, we find that headache and cervical tears are much less in valethamide group, because drotaverine can give rise to many times a sort of precipitate labor, fast actions and fast dilatation of the cervix, which can give rise to cervical tears and PPH also many times. But as valethamide bromide gives rise to a little bit slower rate of dilatation of cervix, we find that there is in this comparative study, the headaches and the cervical tears are much lesser in the valethamide group. So in general, now what are the advantages of using valethamide bromide? Is shortening labor with substantial pain relief, significant amnesia of painful events of labor, average blood loss will be less, duration of all 3 stages of labor was markedly reduced. Like if we say the second stage, which starts from as soon as dilatation of cervix, that is active first stage, then second stage and the third stage of labor, the duration was reduced. Obstetrical management was simplified because of we are augmenting the physics of normal labor, and lowering of the incidence of operative deliveries, of course, because of the rapid progression, and neonatal morbidity and mortality was similar to the control group. So with these conclusions, we can say that we can utilize such medications and such type of pain relief as well as antispasmodics for a better understanding and a better, management of labor, and to get a positive and a good neonatal outcome also, we can use such type of program labor. So thank you all for a patient listening, and thank you. Any questions I would like to answer?
Amazing, very nice, Meenakshi. Very, very nice presentation.
Superb.
Yeah, superb. Too good. Very nice. Yes, Dr. Girish.
Thank you.
Please.
Thank you.
मीनाक्षी खूप छान झालं. मीनू
Thank you,
आपका
thank
भी
you.
बहुत अच्छा हुआ, स्लाइड्स बहुत अच्छे थे.
Thank you, Aarti madam. Thank
और
you.
उसका thank you.
I would also
Madam,
request-
both are like Dhoni and Virat of Pune society. So उनका तो century नहीं होना है. It's expected.
Good one. Good one. Thank you. Thank you. Yeah, we
Uma
are
is there?
hand in hand.
Ma'am, I think Uma madam, there is a network problem because she's traveling back to Pune from Baramati. So I think she couldn't continue for a long time. So anyone, ma'am, Minu ma'am, would you like to give your closing comments on this? So
I think there is net issue with.
there's network.
Yeah. Today there is lot of stormy weather outside.
Yeah, that is the problem. Yeah.
Even I had to come from my clinic to POJ's office today to give this presentation because all the lights are gone. I mean, there's no inverter also now.
Wow.
There's stormy weather outside.
Yeah, so thank you, Meenakshi ma'am, for a wonderful lecture. As always, it's always a learning experience for all youngsters.
Yeah.
And thanks a lot, ma'am, for putting light on some very, very important topic in obstetric. Thank you, ma'am.
Yeah, thank you,
So-
Sandhya.
And we wish that all the youngsters must deliver the patient normally, not with the cesarean. It is a nowadays trend. Take the patient for the cesarean immediately. And demand cesarean is also increasing. Patient demand that we don't want the normal delivery. We don't want to go through the pains and everything. But if you monitor the labor and a plan, like you said, it will be the less painful. And even the epidural is also useful in
Useful.
Yeah.
Yes. Pain
For
relief we
the-
should be giving adequately so that
Yeah. And because of the epidural pain reduces, patient becomes calm down mentally, and the dilatation and descent is fast.
Yeah. Nowadays, what you feel
Because
is, Dr.
of
Girish
the
Mane, you can also comment. Patients are having,
stress relief.
stress of labor. I think stress is more, mental stress and tensions are more for them.
Meenakshi madam, we are fortunate to experience both the scenarios.
I
We
know.
used to work in government college where
Hello.
the facilities of the cesarean section were very less, and the number of deliveries, normal deliveries, I mean, the ratio was tremendous, correct? And even we are
Yeah.
experiencing and we are witnessing the new era also. I mean, the patients of higher age group, higher income, extra knowledge, then lesser capacity,
Yes.
physical capacity, and small
Yeah.
family now. I mean, we have seen both the things. So in my own experience, it is not only the mentality or the thinking of the doctor there, it's changing, but there are multiple issues, I know, I think. So it doesn't only depend upon the doctor and the working pattern of the doctor,
Correct,
but there
correct. That is what.
are external factors also which we cannot change. So now, I mean,
Yeah.
This discussion is endless. So I think it should be personalized, and unless and until the doctor is very much like encouraged by the talk what you have given, it's very difficult to change this. Even madam, law is like interfering in our process. No, so see, what law says, if you are doing cesarean section, then no law will ask you why you have done. But if you are not done the cesarean section, you can be behind bars.
Behind the bars. If you are not done, taken in proper time, that is.
Exactly.
And at the
Means
same
do a
time,
cesarean-
they ask for indication also. I mean, there should be
Right.
some indication and then you should take in time.
Exactly. Madam, you can explain why you have done the cesarean section even though there is no indication, but why you have not done, you cannot explain. So I think there are multiple factors. So it cannot be like a single or one or two factors. So it's a very different subject. But thank you very much
You have
for
to
your
take a
talk. Thanks a
decision.
lot.
You have to take a decision in time for the cesarean.
Exactly.
Yeah.
Yeah, very well said, sir.
Chalo,
And
thank you.
yeah, I know this discussion is never
Endless.
ending, and we can go on for hours together. But
Right.
we will have to formally end this webinar. So I would propose the vote of thanks. So I extend my heartfelt gratitude to Dr. Girish Mane sir and Dr. Kalyan Baramdev for their gracious presence in today's webinar. And thank you, Giri sir, for waiting till the end and giving your valuable inputs. It was truly commendable, all your inputs.
Thank you very much.
Thank you, Yavatmar Society, for their association today, Dr. Charuta Ranade and Dr. Sushma Tarak. Thanks a lot. Thanks a lot for your for agreeing to be a part of this webinar for today's webinar. I would like to thank Dr. Aarti Nimkar, our beloved President POGS, who always encourages us to continue such activities, and her support is truly commendable. Thank you, ma'am. Thank you for your blessings. I would like to thank Dr. Meenu Agarwal for her excellent talk on decoding myomectomy, and Dr. Meenakshi Deshpande for her talk on intrapartum care. It was a truly learning experience for all of us. And at the last, I would like to thank our academic partner BSV, Mr. Prasad specifically, and RX Events, our team for the technical support. Thanks a lot. Without you people, it is not possible to conduct this webinar smoothly. So I would really thank all of you from my bottom of heart for being present throughout the webinar. And also I would like to thank, sorry, I forgot to mention, Dr. Uma Wankhede for chairing the session beautifully. And also Dr. Amol Lunkar sir, who could not join, but he has coordinated with Yavatmar Society and also with Girish sir and Kalyan sir, so that they could be present here and we could listen to them. Thank you, sir. So with this, we come to an end. Thank you. Thanks a lot.
Thank you. Bye-bye.
Thank you, sir. Thank you.
Thank you, ma'am.
Thank you.
Bye, everyone.
Thank you for your moderation.
Thank you, ma'am.
Good MOC.
Thank you, ma'am.